slide. Did that work? Everything is like, okay. Now we're going back over here. Let's hide this. Okay. No, so what we're going to do today is we're going to go through this New England Journal interactive case together as a group. Did not announce in advance what the case is because I know that some of you are sufficiently hardcore to like go look it up beforehand. So we're just running from scratch. 71-year-old guy who was brought into the hospital by his family who has had severe persistent confusions, visual hallucinations, and lethargy. 1 year before he had been normal, but during that year, mild progressive fatigue had developed and he had undergone functional decline. So this is like the culmination of these dwindles. 3 months before presentation, he showed occasional forgetfulness. During the month before presentation, he reported that his vision was intermittently blurry and that he occasionally saw people around him that he knew were not there. During the week preceding presentation, he had become subject to persistent confusion, frequent visual hallucinations, slurred speech, lethargy, and tremor. He had no headaches, cough, chest discomfort, shortness of breath, abdominal pain, diarrhea, dysuria, incontinence, fevers, night sweats, or recent weight loss. And I'm reading this because I'm anticipating that some of you can't see it on the screen. So for those of you who are reading along with me, I apologize. Okay. Brief pause. Please open your participants window and check yes if you've ever done a New England Journal interactive case before. Just want to see how that goes. This is not a poll everywhere question. Not seeing a lot of yeses, but maybe that's because of the technology. There's a few, okay. And some no's, people have figured that out, okay. So there's not too many yeses there, all right. So many of you haven't done these. These are actually pretty cool. For those of you that have done these, I will warn you in advance, they actually are really quite clever at making teaching points for multiple different levels of learner because they have no idea who's doing these things. So I will warn you in advance, some of the stuff we're going through is going to be really basic and some of it is probably going to be more esoteric than you're likely to be able to use. I will try to focus, I'm really trying to spend most of my time on the like resident appropriate stuff and try to hit the middle of that range. But there are going to be a few questions that seem like, oh yeah, whatever, it's really easy, and we'll kind of just blow through that stuff. Okay, on to the rest of his history. He had a history of localized prostate cancer diagnosed 2 months prior to presentation, and his Gleason score was 9 out of 10. He has not yet been treated. He also has histories of hypothyroidism, hypertension, and hyperlipidemia. He was born and raised in Maine. He's married with grown children, is a retired barber, former smoker with a 55-pack year history who quit 4 months ago, drinks alcohol occasionally, doesn't use illicit drugs, has multiple family members with cardiovascular disease, no family history of primary neurologic or psychiatric disease. He is on remarkably few medications, aspirin, thyroid, lisinopril, pravastatin, and tamsulosin, and he is not known to be allergic to anything. And rather than make you check all these boxes, I'm just going to show you all of the physical exam. Obviously focusing on the neurologic exam, he is resting his eyes closed. He is not oriented to self, time, or place. He opens eyes in response to physical stimulation. He follows simple commands intermittently. No abnormalities detected in his cranial nerves. Now, I don't know exactly how they make this 3 out of 5 strength call. I am assuming that they're like kind of manipulating him and maybe he's pushing back. I don't know how you tell 3 from 4 in this context, but they're the New England Journal, so they're obviously right. Couldn't assess sensory function, slightly hyperreflexic in his legs, 2+ in his arms, no Babinski reflex, and his blink reflex and blink reflex in response to threat is intact in both eyes. The rest of the stuff on his exam is pretty normal. His breath sounds might be a little bit coarse. He does not have any hepatomegaly, splenomegaly, or adenopathy. Okay. I would ask you if you have questions about the exam, but that is all the exam you get. Oh yeah, and he's also a little bit hypertensive. Okay, now let's see if we can retrieve that poll. So the next question is, you get to pick 2 of these diagnoses that you feel are most consistent with his presentation. And your options are Alzheimer's, delirium, frontotemporal dementia, rapidly progressive dementia, or vascular dementia. And it is fighting back. All right, this is kind of interesting. Is my poll open on, can you guys see the poll? Okay, Izzy's nodding. There we go. PowerPoint doesn't love me hiding it, I think. Okay, delirium and rapidly progressive dementia are leading the pack. Nobody likes frontotemporal dementia. All right, that's enough data for me. So I'm going back here, and we're going to check delirium and rapidly progressive dementia, and you got them right. And so the teaching point that they want me to make here, which I'm sure, like I said, some of these are basic, is what you keyed into as well, is this is just moving really quickly. And it's moving too quickly for an uncomplicated Alzheimer's or frontotemporal dementia. Vascular dementia, I guess in theory, if he had the right stroke in the right place, he could go off a cliff like this. But the two of these that are most characterized by moving at this kind of a pace of kind of like maybe a little bit of gradual progression and all of a sudden, boom, would be an acute delirium for reasons unexplained, or if he had a rapidly progressive dementia disorder that was evolving over weeks to months rather than years. So great. This one, I'm just gonna, well, I guess we'll do it. How are we doing? We're limited for time. Okay. Go ahead and let's do these really quickly if we can. Let's see how well this works. So they want to know which of these features are characteristic of which disorder. So you've got dementia, delirium. I don't think this is going to work. Nope, and this is not a fun part. So I'm just going to talk at you. So dementia, delirium, we'll go with acute onset. What do you think? Progressive worsening of symptoms? Anyone voting here? Train wreck. Oh, there we go, there we go, there we go. Oh, people, are you already on impaired alertness? All right. Let's just check some random boxes and display the answers. Progressive worsening, definitely dementia, impaired alertness, let's say both. Impaired thought process, let's say both. Difficulties with speech and language, kind of both. All right, and good, we did okay there. Yay. So they're saying, what did I miss here? Impaired alertness is impaired, oh, okay. I guess it, but can also affect in the later stages of dementia. Yeah, okay, fine. Yay. Yay. All right. Moving on. This is his MR. And what you're seeing here is the periventricular white matter disease you often see in hypertension, and they're trying to point out, I think, a little bit of volume loss over here on the edge. And here are his labs. So, notable findings: low hematocrit, normal white count, interesting looking monocytosis, decent platelet count. Chem 7 is pretty normal. Bicarb of 21 is technically low. Calcium is fairly impressive, 11.7, and an ionized calcium of 1.55. PTH is low. I love that all the labs come back immediately when you send them in online cases. Total protein is high at 9.0. Albumin is low at 2.8. LFTs are normal. TSH is normal. Ammonia level is normal. Vitamin B12 is high. RPR is negative. ANA is negative. SED rate's quite high at 114. HIV and Hep C are negative. CRP is actually pretty normal. Beta-2 microglobulin is high. And then his CSF has a little bit of a high protein, otherwise pretty normal looking. I'm not going to scroll back through those. I'm hoping that you guys noticed which were abnormal and which were interesting to you. Okay, now let me get this thing to the slide I actually wanted on so that y'all can vote on what's going on with him. Come on, Polev, do your thing. Okay, here we go. Symptoms of hypercalcemia. So what I want you to do is just put in symptom. Oh, wait, I went one slide too far, didn't I? My bad. This is what I want. I appreciate you guys' patience. This is actually giving me more trouble than the last time I did this with the students. Can you answer? Here we go. Okay, so you get to vote for what's causing his hypercalcemia. And your options are vitamin D toxicity, hypercalcemia of malignancy, hyperproteinemia, hypoalbuminemia, metabolic alkalosis, primary or secondary hyperparathyroidism. Only 9 votes, but everyone likes hypercalcemia of malignancy. Yeah, right? He's got at least one cancer that we know of. He's also got a long smoking history. So going through this, vitamin D toxicity we would have known about because we measured it. Hyperproteinemia can certainly cause an elevated total calcium, but should not cause his elevated ionized calcium, which is actually, I think, more dramatic than his total calcium. Hypoalbuminemia only affects the total calcium as well. I think metabolic alkalosis can actually, I think it increases, it's in here, let's look it up. I think it increases binding to albumin. What does it do? Yeah, so it increases ionized calcium's binding to albumin. So it can actually cause a higher total calcium than the ionized calcium would reflect. And then primary and secondary hyperparathyroidism, his PTH is normal, so he doesn't have those. Cool. So now we get to the, you get to type slide. So put in some symptoms of hypercalcemia. See what you like. This PowerPoint thing does not make me happy. Abdominal pain, acute mental status changes, confusion, abdominal pain, fatigue. There's the nephrolithiasis, okay. Yeah, so we're thinking, you know, bones, stones, groans, all that stuff, exactly. Okay. Hyporeflexia, nice. Cool. Okay. So I think you guys know these, but there's your confusion. One thing to remember is that it actually does shorten the QT interval, which generally speaking, it's unusual if that's a big deal, but if they're severely hypercalcemic, it can be. And then here's your nephrolithiasis. Nephrogenic DI is actually something that I didn't know about and have never seen. Here's your GI stuff. And then here's your bone pain. I want to walk briefly through this. And the reason I want to walk briefly through this calcium homeostasis slide is because I hate it. And like rehearsing it, I feel like is good for me. Divalent cations just drive me nuts. I feel like I never understand them. But so basically to remind you guys of all the players in this. So player number 1 are the kidneys, rid of calcium. And then player number 2 is the gut. It absorbs calcium. One of the reasons why I think I find calcium so hard to understand is because there is this enormous reservoir of calcium in the bones. So all of the stuff that's happening over here can be balanced out over the long and the relatively short term by what's happening over here. And this just for me, this makes homeostasis very hard to understand. I think the key things to remember, parathyroid hormone serves to drive up calcium both by reducing renal resorption or by increasing reabsorption from the kidneys and by liberating it from the bones. And then vitamin D is acting, oh yeah, this is showing us the hyperparathyroidism. So if you have primary hyperpara, it does this. And if you have malignancy, it can either create PTHRP, which acts in the same way as hyperparathyroidism, or it can act directly by bony destruction, which is just going to liberate the calcium ions from anything that gets eaten by the tumor. So lung cancer, more typically are PTHRP mediated, whereas something like myeloma that's actually just destroying bone may simply be liberating calcium. And then vitamin D's primary site of action is over here in the small intestine. And this is where they put in their differential things like sarcoid that actually activate vitamin D, that independently convert 25-hydroxy to 1-alpha 25-hydroxy vitamin D. So put that in there because I like the diagram. It makes me feel like I can understand stuff a little bit better that I have trouble getting my head around. Oops. They also have a nice, I like their etiologic algorithm, which is basically, is the PTH too high or not? And then if the PTH is too high, you go down the hyperpara pathway. If the PTH is not too high, then is the vitamin D level too high or not? And if the vitamin D level is too high, they're vitamin D toxic. And if not, then you get into all the other stuff that we think about, which is actually a pretty short list on their algorithm, but just that makes it seem simple. And then treatment, don't think we need to spend a ton of time on treatment. I think most of you guys know how to do this. The one that was on here that I have never used, I'm not sure if anyone in the audience has, is calcitonin. It does work. It tachyphylaxis fairly quickly. So the goal with calcitonin, if you use it, is to kind of bridge between the IVF phase and the bisphosphonate phase, hitting this 4 to 6 hour window. I've never pulled it out. Okay, now let's see if we can move ahead here. So give me one diagnosis. So this is probably the first question that is of sufficient difficulty for a resident audience. Let's see how you guys do. Do you want Creutzfeldt-Jakob disease? Do you want metastatic prostate cancer, myeloma, SLE, or viral encephalitis? Well, I did it again. Is it gonna work? Is it gonna work? Is it gonna work? It's starting to work. No, it's not working. Work. Somebody vote. Okay, the myelomas are coming in. The prostate cancers are coming in. So for those of you who ever, take up as an occupation or as a side gig writing multiple choice questions, this is a really good illustration of how hard it is to write a good MCQ. In the sense that there's only 2 possibilities here, and y'all like myeloma. Throw some stuff in the chat as to why you like myeloma better than Mets. None of these other 3 presentations, Creutzfeldt-Jakob, lupus, viral encephalitis, would explain the existing picture. So it's a good example of how hard it is to write a question. Nobody's saying anything about why they like myeloma better than prostate cancer. I'm assuming that probably most of you noticed, yeah, that giant protein gap and or the high level of beta-2 microglobulin. So we're gonna not read this because y'all got it right. So what they did is they went on to do SPEP, and the SPEP interestingly showed this massive spike in IgA. So he actually has an IgA kappa multiple myeloma. And what's interesting is, as you see sometimes with IgA up at the top here, he actually had a double M spike, because what happens is some of the IgA dimerizes. So you get one spike for the monomers, which is the point, which is usually smaller, and then one spike for the dimers, which is usually larger. His was 3 grams of dimer and 0.46 grams of monomers. And as you would expect for IgA kappa, also really high levels of kappa-free light chains. So I'm going to skip the epidemiology and pathogenesis and clinical manifestations of myeloma, assuming you all know that. I'm just going to do 2 quick things on staging and prognosis and treatment. And the reason why is because this is where I learned something. Now, you are far more current than I am about things like hem-onc, but I did not realize when I was going through this either that the primary element of staging is the beta-2 microglobulin in the serum, and that the survival is actually not bad anymore. So for these folks with stage 1 disease, the 5-year survival is 82%. Even with stage 3 disease, the 5-year survival is 40%. And presumably what's driving that is this combination of the immunomodulators, which are the itamides, and the proteasome inhibitors, which are the various myeloma-specific MIBs. We still give people steroids. You can still transplant people, and frequently do if they are eligible. But this is like all new stuff for me, and definitely I learned a lot here. I'm guessing most of you have probably already seen this, But to me, the take-home point is the prognosis for myeloma is not nearly as bad as it used to be, and there's a lot of new stuff that they're using and a lot of other stuff that they're working on. But we're not done. So now you get to vote for everything that you want to do next for this guy. So one option would be to marrow him and wait to see what you get before you start anything. One would be to start pheresing him. One would be to start chemotherapy. One would be to measure his plasma viscosity, looking for hyperviscosity syndrome, and wait for that before you start pheresing him. And one would be to treat hypercalcemia. So please vote for everything. Just remember, if you vote for test and wait, then you don't get to do the other stuff. Okay, lots of good residents want to treat the obvious hypercalcemia. Down there with that. Nobody's excited about testing his viscosity. Few people are like, yeah, let's go ahead and treat the guy. One person wants to biopsy and a couple of you want to pherese. All right, so let's go over here and we'll actually go through this and see what they say about these answers. So your first one was treat hypercalcemia. That got the most number of votes, and they like that. Yes, please treat his hypercalcemia. That was done by day 3. His calcium fell down to 8.3 mg per DL. He actually did get calcitonin, so he got fluids, calcitonin, and a bisphosphonate. Strong work. Okay, next I believe was chemo. So let's do that. Yes, chemo is good. Thank you. And he got bortezomib and dexamethasone, and that actually helped too. Now, for those of you who are reading the fine print, next choice, I think actually your next leading choice was pheresis. And they thought that it was possible that his mental status was related to hyperviscosity syndrome. So we're going to spend a little time on hyperviscosity syndrome next, but they liked that idea. The two things that they did not like are don't wait for the biopsy results, because he's obviously hypercalcemic and there's lots of things that you could treat, lots of ways that you could treat him before you do the biopsy. And please don't wait for your viscosity results, because it takes forever and it doesn't actually typically change management a lot. I mean, if it's normal, then it tells you that you didn't need to treat them, but the level of elevation in viscosity doesn't correlate well with the severity of symptoms. So if you suspect hyperviscosity, measure, treat, wait for results in that order. So yeah, so this is basically telling us the same thing I just told you. He got treated for hypercalcemia, myeloma, and hyperviscosity all at the same time. And then this is what I thought was interesting about this. So typically when I think of hyperviscosity syndrome, I think of Waldenstrom's, which is an IgM plasma cell disorder. And that is because I'm thinking of this beautiful picture here of IgM making these pentamers, which actually make this plasma very sticky. I do not usually think of IgA, but IgA, because it dimerizes, actually can also predispose to hyperviscosity in high numbers. So that's what they were worried about with this guy. And among the symptoms of hyperviscosity are a bunch of non-specific neurologic stuff, confusion, blurred vision, headache, that type of stuff, as well as more specific things like the retinal hemorrhages that you're seeing here. So their take-home point on this is to think about it also when you have IgA, and to, if you suspect, treat rather than wait. After 3 days, his calcium level came down. His IgA fell from 4 mg per DL down, from 4 grams down to 1 gram with 2 pheresis sessions. He actually woke up, became conversational, was oriented to self, place, and time. Still didn't remember the previous week, not totally surprising there. His viscosity was 1.7 centipoise. Yes, that is an actual metric. Look it up on Wikipedia. Normal is less than 1.5. And here you have the beauty of our August colleagues at the New England Journal saying two things that completely contradict each other in one sentence, which is it does not normally reliably correlate with the severity or extent of symptoms, comma, but mental status and cognition generally tend to worsen at higher levels of viscosity. I don't know which point they're trying to make. Either it does or it doesn't correlate, but regardless, their conclusion was, well, it was only mildly abnormal, so it was probably more the calcium and just everything syndrome rather than specifically hyperviscosity. But, you know, we replaced his plasma volume anyway, because that's what we do. He did get his skeletal survey, and here you can see some holes typical of myeloma. There's some nice little kind of moth-eaten stuff, particularly here in the humerus. And as expected for someone this age with multiple comorbidities, he didn't do super well. He did end up getting a bone marrow biopsy. He had 5 to 10% of the bone marrow consisting of clonal plasma cells, 10 to 20% focal aggregates. By the time he got his biopsy, his IgA had nearly normalized. But then he got pneumonia, and I think because he had 2 malignancies and some underlying cognitive disorders, it sounds like the family chose hospice. So, not a surprising ending to the story. But that was that case. Now, if y'all want to do another one, I have one more that we can try to do, or you can say you've had enough, or we can take a break. So let's see. If this slide works, I'm definitely going to use a different, I'm not going to use the PowerPoint thing if we keep going. Okay, most of you want to keep rolling. So it's 10:45. Give me 5 minutes to get the next case set up. I'm not liking how PowerPoint is working for me here. So I will start the next case at 10:50, and in the meantime, talk amongst yourselves. So that was interesting. Somewhere in the midst of all that, I quit Zoom by accident, and the only way that I noticed was the fans on my MacBook Air suddenly started slowing down. I'm like, uh-oh, that's bad. All right, y'all good to go? Somebody turn your screen on and wave at me. Thanks, Izzy. I need a little bit of emotional support here. I don't feel like the last one went very well. All right, let's try another. So this is a 64-year-old woman who presented to the emergency department with fatigue and shortness of breath when walking short distances or climbing stairs. She had severe fatigue with minimal physical activity that had progressively worsened over 3 months, reported having nausea and loose stools during this time, and had lost approximately 5.4 kilos since the onset of symptoms. In the week before presentation, she felt lightheaded and had 2 falls, but did not lose consciousness, had no chest discomfort on exertion, no cough, fevers, or chills. Here, I'm going to give you the rest of this information and then have you work on a differential. So history of reflux, migraines, SVT, and depression. She takes metoclopramide as needed for migraines, sumatriptan as needed for migraines, and then verapamil presumably for her SVT. No known drug allergies. She is a retired nurse. She's married with 2 adult children. Former smoker with a 17.5 pack year history who quit 3 years ago. History of alcohol use disorder but hasn't drank in 3 years. Brother with type 1 diabetes, daughter with antiphospholipid antibody syndrome. And let's go here. I was pausing to see if I wanted to have you do a differential now, but let's do the exam as well, and then you can do your differential. Temps 36.3, heart rate's 91, blood pressure is 96/50, respiratory rate's 18, O2 sat's 100%. She's thin and fatigued with conjunctival pallor. Remainder of her exam, pupils equal round and minimally reactive, mucous membranes are moist, conjunctival pallor again noticed, no icterus, no adenopathy. Lung exam is normal, heart exam is normal except for a 2 out of 6 flow murmur at the left upper sternal border, abdomen normal, arms and legs normal, no edema, skin normal, neuro normal, stools guaiac negative. Okay, go to Poll Everywhere and start putting in differentials. And this is an upvote. So if you see one that you already, if you see one that's already there, you can just vote it up. You don't have to re-enter it. Anisha wants to see the HPI again. Okay. She knows where the money is. There's actually not a ton in this HPI. It's basically 3 months of increasing shortness of breath and a 5 kilo, AKA almost 12-pound weight loss. C. diff colitis, colon cancer, okay. Anemia due to occult GI bleed, all right. GI malignancy, GI. All right. I know there's 20 of you out there. More anemia, adrenal insufficiency. Lymphoma, oh, that's interesting. More GI. So people are liking anemia, occult GI bleed, which may or may not be due to cancer. Another vote for adrenal insufficiency, because everything can be endocarditis, right? If it's coming out of Boston, it's probably endocarditis. Malignancy plus too many stool softeners. I didn't even tell you she was taking any stool softeners. I didn't. But who knows? Maybe she's like sneaking the Miralax. All right, so we're pretty, I'm seeing a lot of anemia here. I'm assuming that you guys locked into the conjunctival pallor as like the only relevant finding on exam. So let's examine your hypotheses. So her hemoglobin is 4. Yes, that is right. 3.8. Her hematocrit is 12. No, those numbers are not reversed. So yes, you are right. She is anemic. Her white count is actually also fairly low, 1.9, and then her platelet count is preserved. She has an MCV of 112, RDW of 18.6, and a retic count of 0.7. And the rest of this stuff, her bicarb is 15, and that's also kind of notably abnormal. The rest of this stuff is not a whole lot to write home about. Alk phos is a little high at 189. B12 is 281. Thank you for giving us that. Folate is also normal. MMA level is normal. Homocysteine is normal. And our TSH is 2.28. So thank you for those of you who suggested anemia. We'll explore more the causes of her anemia in a minute. I am guessing, or at least I am hoping, that when many of you are looking at this MCV, that you are taking, that occult GI bleed is actually moving down your list, because typically people who are anemic from an occult GI bleed, we're going to have a low MCV because they're primarily going to be iron deficient. There's probably something else going on here, and we will work on what next. One other sidebar that I just wanted to comment on. I know that many of you have seen and remarked on the kind of remarkable ability of COVID to cause silent hypoxia. Just a reminder that we have lots of experience with people having really, really low oxygen carrying capacity and tolerating it okay. So if you were to think about what is her oxygen carrying capacity relative to what it should be, it's about 25 to 30% of what a normal full-blooded person would be. So this lady has basically acclimated to some incredibly high altitude that I haven't computed. One of you who's an altitude geek can go look at that. But she's doing okay with her hemoglobin of 12, presumably because she got there slowly. I have always found it to be very interesting why we treat an O2 sat of 50 as being completely incompatible with life, whereas a hematocrit of 12 certainly gets us excited, but it doesn't get us the "you must transfuse them within minutes or they will die" kind of excited. So I don't know, interesting. I thought that was an interesting thing about this case and about how we see we see tissue hypoxemia from bad gas exchange, and we act differently than we do from anemia. I'm looking back at the differential list. Oh, malabsorption is on there now. All right, all right. Maybe we're getting there. Okay. This is a little, this is just talking a little bit about macrocytic anemia. The things that I want you to focus on here is how they define megaloblastic anemias. So the classic megaloblastic anemia is B12 deficiency, but it's also anything else that impairs DNA synthesis. So that can also include things like antimetabolites. So azathioprine and various other chemo/immunosuppressive drugs can also cause megaloblastic anemias. The classic finding of megaloblastic anemia is the hyper-segmented neutrophil. Macrocytes are another thing that you should be looking for. Poikilocytes and an isocyte on the smear, I mean, those are fairly nonspecific. So poikilocytes means all different sizes, and isocytes means all different shapes, I think, or maybe no, that's backwards. Poikilocytes is shapes, and isocytes is sizes. Neither one of them is terribly specific. So when you're looking for megaloblastic anemia, look primarily for hypersegmented neutrophils and macrocytes if you can. Knowing that, when you look at this differential for megaloblastic anemias, it's actually pretty easy. It's either B12 folate or it's medication toxicities. Methotrexate 5-FU, azathioprine, mycophenolate. So a lot of things that we're familiar with as either chemo drugs or immunosuppressives. The non-megaloblastic tree is a little bit more interesting. The first thing you do is you exclude reticulocytosis, which is obviously because reticulocytes are big, they're going to expand both the RDW and the MCV. So if reticulocytes are up, then you go down that pathway. And then if they're not, you get into kind of this weird stuff. Myelodysplastic syndrome is sort of what we think of a lot. Hypothyroidism, pretty rare complication of that. Liver and alcoholism, pretty common. And copper deficiency is pretty rare. So what we're going to do is go through a few cases just to work through macrocytic anemias, and then we'll come back to our case and figure out what's actually going on with her. So this case, we're going to use Pull Everywhere a lot more here. So this is a 60-year-old woman with lupus and lupus nephritis who has a 3-week history of lightheadedness, transient chest pain, worsening shortness of breath. She has a hematocrit of 20, hemoglobin of 7, white count of 3.5, platelet count of 140, MCV of 106, retic count of 15, LDH of 1,000, and a haptoglobin of less than 8. So the first question is, do you see megaloblastic features here? Go ahead and answer. Poll everyone's waiting for you. I'm waiting for you. One vote for no. 2 votes for no. Right. So looks like it's an exclusive no. So you can approach this in one of 2 ways. Either you can say, I don't see any of the stuff he told me to look for. I don't see any hypersegmented neutrophils. Don't really see any macrocytes. Or you can say, gosh, he just read me a bunch of hemolysis labs, and so I should be looking for findings of hemolysis. So hopefully what you do see are these piles of shift cells, which is what you call a reticulocyte before you stain it for reticulin. So all of these like slightly bluish, relatively large red cells are reticulocytes, or will be once you stain them. So I would say yes, correct, no macrocytic features. Moving on. Do they have an elevated reticulocyte index? I am not going to make you vote on this one because their reticulocyte count is 15. There is a convenient calculator here for how to calculate the reticulocyte index. And basically what you're doing with this is you are using the percentage reticulocyte count and the ratio of their hematocrit to a normal hematocrit to compute an absolute retic count. If you actually have an absolute retic count measured by the lab, you don't necessarily need to calculate a reticulocyte index. Yes, so she has lots of reticulocytes. Okay, so the next question is, what did you see on that smear? So yes, there's reticulocytosis. What is the other finding on this smear? You get to vote twice. Oh, I'll show you the smear again. You don't need to see your answers. I'm interested in your answers. You're probably more interested in the smear. So just as a reminder, let me just look here real quick. Okay, so we're looking for hypochromia, so that would be kind of pale cells. Spherocytosis, and when you're looking for spherocytes, you're looking for cells that do not have central pallor. The classic spherocyte is actually going to get darker as you move towards the middle of the cell, but cells without central pallor are what spherocytes look like. And reticulocytes we talked about. Basophilic stippling is when you have like bluish dots in the red stuff. And then target cells look like targets. Hopefully most of you have seen those because they're common in liver disease, and we see an awful lot of liver disease in our program. Let's see how the voting's doing. Spheres and retics are leading. Click, click, ding, ding. Strong work. All right. And okay, finally, what is causing this patient's problem? I'd say don't take all day here, gang. Yes. In terms of which of these things causes reticulocytosis, I mean, medication effect can cause reticulocytosis if it causes hemolysis. Kidney disease shouldn't, B12 deficiency shouldn't. So yes, she has hemolytic anemia. Moving on, next case. Okay, advance this. Okay, let's vote on megaloblastic features here. So what I'm seeing, this streak across here is preparation artifact, and I'm guessing the fact that some of the cells look a little munchy crunchy are as well. For those, just out of curiosity, click yes in your participants if you've ever yourself prepared a blood smear. Anyone? Anyone? All right, we've got a few. Yeah, it's good. So blood smears are not super technical. I mean, what you actually do is you put a drop of blood under a cover slip and you literally smear it from one edge of the slide to the other. And what that does is that results in a decreasing density of red cells as you go from where you start to where you finish. You know this from when you look at blood smears, that as you pan left to right across the slide, there's a part that's too thick to read and there's a part that's too thin to read. And what you're looking for is the part in the middle where you have a reasonable number of cells and can get a good look at them, but they're not like all squished together. So that's what you're trying to do to avoid these artifacts. This one got a little bit dried. 3 people said megaloblastic features, 1 person said no. So that's what we'll vote. So we're going to come back to this little dumbbell-shaped cell and ask, is that hypersegmented? The actual definition of a hypersegmented neutrophil is 5 or more lobes. That pretty clearly has 2, so that doesn't make the cut. And some of these things are clearly ovalocytes. Macroovalocytes is a tougher call. I'm not sure if we have any future heme fellows in the audience who want to speak up on that. But they said no. Okay, let's look at the numbers. Hematocrit of 30, hemoglobin of 10, white count of 2,000, platelet count of 80,000. So none of those cell lines are normal. MCV of 108, retic count of 1.0, LDH normal, haptoglobin high, B12 normal, folate normal, TSH normal. So I will once again answer for you and say this person does not have a reticulocytosis because they pretty obviously don't. And now we're going to find out if there's any future heme fellows in the audience because we're going to play Name That Cell. That's right. Has any of you ever met a dumbbell-shaped cell like this before? God, I'm always stunned by how much smarter you guys are than I am. Oh, man, it hurts. It hurts. Yes, so far, everyone who has bothered to answer has answered correctly. I'm not going to make you go turn on your audio and tell us what this means. But yes, this is a pseudo-Pelger-Hewitt anomaly. Interestingly, a real Pelger-Hewitt anomaly is associated with a genetic mutation in the LBR gene, but the pseudo-Pelger-Hewitt anomaly is an acquired phenomenon that looks like the same thing, and it is associated with myelodysplastic syndrome, AML, CML, various hematologic nastinesses. So my hat's off to the three of you who knew that. I had no clue. And honestly, I just ran through this last week and I almost had already forgotten it again by now. So strong work. Okay, so knowing that, what do you like as the cause of this person's macrocytic anemia? Your options are drug toxicity, folic acid deficiency, liver disease, MDS, and vitamin B12 deficiency. And all right, well, I'm not gonna make any more of you vote. Yes, that was myelodysplastic syndrome. All right, third and final test case, 2 smears. Let's look for the, I will activate the poll, and I will first show you this one. And yes, I would love to be able to zoom in on that neutrophil as well, but I see 1, I think this is 2, 3, and I think this is 4, 5. That's that. Lots of funny shaped cells here. Teardrops and more teardrops. I think there might be, this might be a spur cell or a Burr cell here. Let's look at the other one. There's a target over there. See what we've got in this other one. I'm still looking for a macroovalocyte. This just kind of looks gnarly. This might be a macroovalocyte here. Everyone says yes, because after all, we've had 2, we only have 3 cases. So one of them has to have megaloblastic anemia. And her MCV is 120, her hematocrit is 14. She has a history of Crohn's, underwent ileal resection 3 years before beginning treatment, and now has had shortness of breath and fatigue and numbness and tingling in her toes for 3 to 4 weeks. Interestingly, her B12 and folate levels are conspicuously absent from the labs that we were given this time. No, she does not have a reticulocytosis. And I will show you these things again. Which features do you want to vote for? Spherocytes, some targets. Okay, I'm seeing hyper-segmented neutrophils and spherocytes. Oh, but targets are catching up. Spherocytes are still winning. Here we go. Now, see, they wanted you to find macroovalocytes. I was also not. Macroovalocytes arrowhead. Okay, yeah, so they're saying this little guy is a macroovalocyte. All right. Maybe that one too. And then the hyper-segmented neutrophil is the one that we saw earlier. Okay. And cause of this person's macrocytic anemia, go. At least they did us the courtesy of including multiple different things on this. Oh, wait, sorry, did I do something wrong? Oh, here we go. Multiple different things that might actually cause the problem. Slightly better written MCQ here. Everyone's liking B12 deficiency. And there's 2 clues to the B12 deficiency here. The most obvious one is the neuropathy. Folate typically does not do that. That's a much more characteristic thing of B12. But the other thing that I think is notable about this as a case of B12 deficiency is the fact that the inciting event, the ileal resection, was 3 years before she began to have symptoms. And that is because you can store a lot of B12 in your liver. So this is not an uncommon history of people having whatever caused them to malabsorb B12 can be present for a long time before they actually develop symptomatic B12 deficiency. Cool, all right, we've gone through our test cases. Now we are on to the real deal. So, same drill, 3 slides to look at. These are the same labs I told you about earlier. So first we have the too numerous to count slide. I'm not sure why they even gave us this one, but I guess what we can see is that there's not a ton of white cells in there. Then we have this one. So relatively normal neutrophil. What else am I looking at here? Some fat things, which might be platelets. That might actually be a nucleated RBC. These look like platelets. And slide number 3. Sorry, I haven't activated this. I'll let you guys vote. There we go. A lymphocyte, a couple more platelety looking things. All right, so far we have a unanimous no. Correct. Do we need to do the math to tell that she has a, no, we do not. Her reticulocyte count is 0.7. Well, because this is our real patient, we'll actually put it in just to confirm. 0.7 her hemoglobin, and because her hematocrit is like super low. But it's gonna be really, 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 really low. Yeah, 0.2. No. Skip that question over here. And move on to the next question. All right, now you get to pick 2 possible causes of her anemia. Your list is alcoholism, copper deficiency, hemolysis, hypothyroidism, liver disease, or myelodysplastic syndrome. Okay, no surprise, MDS is leading the pack. MDS, copper deficiency, only 12 votes. There's 20 people out there. Come on, don't be shy, people. All right, looking like MDS and copper deficiency. Ding, ding. All right, so props to you who remembered the diagnostic algorithm I put on there earlier and the fact that copper deficiency was on it. I personally would have wondered about liver disease as well, but you know, her LFTs are normal. She says she's quit drinking, so, and we've already established that y'all are smarter than I am. Is that all there are for questions on this slide? Yeah. Okay, so what we have here, I'm just gonna advance this and activate it before I forget. Oh, that's all for that. Cool, all right, we're done with the question part, so let me just walk you through the rest of this. So this is her marrow. It actually has relatively normal cellularity. And then these are hyperlobated megakaryocytes, which is apparently a thing, copper deficiency. And then what do they want us to see in C? Cytoplasmic vacuoles and erythroid precursors. So brief sidebar on copper. So one of the reasons why we rarely see copper deficiency is because it's in a lot of different stuff. So essentially, if you're eating grains or vegetables, then you should have a reasonable amount of copper intake. So largely, it's going to be malabsorption syndromes that cause copper deficiency, or TPN, in which the copper is inadequately supplemented, which isn't supposed to happen but can. Interestingly, I didn't know this part, that zinc actually competes with copper for absorption. So if you take a ton of zinc, that can apparently cause copper deficiency. I am not going to go through this because this is like way too basic sciencey for me, but know that it's there for those of you who want to come back to it later. You can find it on the New England Journal website. And then the clinical manifestations, it actually does produce this kind of almost pseudo-myelodysplastic syndrome that we're talking about now. Also can have peripheral neuropathy, which looks a lot like B12 deficiency, so that's kind of interesting. And then brittle hair, dry skin, and some skin changes along with that. So pretty strange. So she actually underwent endoscopy looking for why she was copper deficient. And what you're looking for here is this kind of like characteristically smooth duodenum that has no visible villi in it whatsoever. And this is the scalloped duodenal bulb. So those are the gross findings of celiac disease, and they didn't give us, I guess they didn't give us a slide for histology. So this thing I thought was kind of cool because what they did here is showed you, this is her hemoglobin down at the bottom, and she got 5 units. So they gave her 3 and bumped her up to 20 right up front, and then gave her another unit here on probably hospital day 2 or 3. It took, I'm guessing, 5 days for the copper to come back. And then as soon as they started IV copper, you can see her red cells starting to creep up, but look at what her white count does. Her bone marrow is like, oh yeah, that's what I needed. And her white count is recovering within a week, and her hematocrit is climbing up as well. So very satisfying. She went on a gluten-free diet. Oh yeah, here's the histology. I knew it was in here somewhere. And her villi looked better. All right, so that was your sufficiently wildly obscure case of macrocytic anemia, but kind of cool. And actually, if you go to this, if you search for element of surprise or copper deficiency on New England Journal, there's actually a good accompanying review paper on copper deficiency. If you're interested in that, I encourage you to look for it. That's all I got. So it's been fun. I noticed it quit raining and the sun is shining. So maybe some of you will get to go out and enjoy that now. Have a good time. Thank you for hanging in with me for 2 of these cases, and I'll see y'all later. Stop that. And stop that. And bye-bye.